Yes, first of all, I would like to thank the organizing committee and especially Kostas Parias for the kind invitation. I will present a case. Sorry. I'll present a case which is not something special, but I think it is interesting. In our center, we had a 70-year-old lady. She had an operation in 2012 when the surgeons, they gave her a lima to the LAD, and they replaced the aortic valve with, because of aortic stenosis, with a Sorin solo free solo valve, a biological valve. From other situations, she was under drug medication for hypertension, hypothyroidism, and she was with a problem with her kidney disease. And then she came back with aortic stenosis. The lady, she was referred to us from a peripheral hospital, and we performed a coronary angiography, and this gave us the information that the lima was patent. She was having diffuse disease, which was already known from the first case, I mean, the first operation, before the first operation. So they performed a stress echo with no ischemia, and the Euro score was 4.33. And we decided to go for a TAVI replacement. When you have when you find about this freedom solo, which was a 33 millimeters valve, you have in your mind that you could use all these valves, and we decided to go with a portico, actually an Avidor 25, what it was available in our hospital at that case. We have from the CT scan, you could see how it was, and there was any sign of calcium. And again, if you measured the valve, it's the 25 that you could decide to use for the lady. This is again from the CT scan, and another scan with about the coronaries, which we didn't have any problem for that. This is the valve, and the main problem with that is if you didn't know that she had the operation, you couldn't identify the valve, and you didn't have any sign of to go by the procedure of the TAVI. And this is not what we found, but generally with this kind of a valve, there are no signs to use when you are trying to do the replacement. So this is from the operation. There was about 50 millimeters peak gradient for the valve, and this is before the insertion of the valve, and sorry, and this is when we try to have the valve in place. The main problem with that is that you should go quite inside in order not to, because you don't know where exactly is the previous valve, as you can see, and it's what we tried to do. But by the end of the procedure, we had again about 20 millimeters of gradient, and then that's where it started the interesting of the case. We should be sure if the valve it was in the standard place and it was safe to use a balloon to expand that. And what we tried was, first of all, have at the same time LV angiogram with aortic angiogram, and we saw that it was okay. And what you can't see, because we had a technical problem for the presentation, it is we did immediately a TOE, and the images, they were fine, and it was what we used to give us the confidence to proceed with a balloon. And we did the balloon, and this is the balloon, although the image is not convincing that it was solved the problem was was solved, because there was no any gradient after the ballooning that we did. So that's the end of the presentation. What's why we saw that, and we think that it's interesting. It's not easy to find this kind of valves in every day, and it's that you should plan very well the implantation, and that to be and to have at the site of the TAVI procedure the TOE to be accessible to assess the implantation if it is needed. That's it. Thank you.
Thank you very much, Dr. Zarifis. Do you have any comments? Okay. Any comment from the panel or from the audience?
Congratulations for a very nice case. This is indeed very rare case to find the stainless valve, which is degenerated, and put a new valve, which makes it a complex case. Regarding your strategy, first question, how did you choose a 25 versus a 27 valve? First question. Second, what was the pre-dilatation balloon that you used, and what was the post-dilatation? I mean, as a sizing.
We did do pre-dilatation. We just went with immediate procedure with the valve, and the post-dilatation it was with a 23 balloon with some extra contrast in the site, and this came according to the measurements we had from the CT scan, which gave us the diameters that we could use, and the results seems to be quite good from what we had, and the lady is very well at the moment as well.
In any case, it is difficult to put a valve without landmarks. There are not.
Yeah, that's it.
You were blind, and also it was strange in a 58-year-old woman at the initial surgery to put a bioprosthetic valve, and he had also chronic kidney disease. Maybe a mechanical valve was better at the as initial strategy, but also in this situation I prefer to put a supraannular valve. The gradient will be lower, and maybe a bigger valve, but your result was perfect, and we have to congratulate for that. Any other comments? Otherwise, thank you